Good evening, everyone. Welcome to IPNA Webmaster Series 2020. Now we are in webinar 20. So we have three eminent speakers for the day, Dr. Satya Prasad, Dr. Ravikumar, and Dr. Muthiah. And so today's talk will be moderated by Dr. Satya Prasad. Dr. Satya Prasad is a pediatric nephrologist at Rainbow Children's Hospital, Hyderabad. He has completed his MD Pediatrics from Kuntur Medical College, and he has received his IPNA Fellowship from All India Institute of Medical Sciences, and he has an extra training of fellowship in pediatric nephrology at Singapore, and his area of interest is towards renal vasculitis and intensive renal care. He is a recipient of several awards, and he has conducted several conferences and conducted many workshops on CRRT and peritoneal dialysis in children. So he'll be moderating the session for the day. Over to Dr. Satya Prasad.
Thank you.
Satya Prasad,
Good
sir, you're
evening,
there?
all. Hello?
Yeah, you're heard, sir.
Yeah. Good evening. Welcome to Webmaster Series. In today's session, we are going to discuss about kidney-specific fluid therapy in PICU and metabolic acidosis in sick children by two eminent speakers, by Dr. Muthiah Periyakaruppan and Dr. Ravikumar. First, just I'll go through the introduction. Coming to kidney diseases, why early diagnosis is so important? If we can diagnose early, we can preserve kidney function and we can prevent irreversible kidney injury. Pre-renal injury is quite common in children with multi-organ dysfunction, especially if associated with hypovolemia and hypertension. And this often leads to intrinsic kidney injury if not promptly corrected. The prescription of intravenous fluids requires an understanding of fluid homeostasis and should be tailored to the individual, the disease, and the intended therapeutic goal. Coming to metabolic acidosis. Metabolic acidosis is an acid-base disorder characterized by a decrease in serum pH. Thus, that results from either a primary decrease in plasma bicarbonate concentration or an increase in hydrogen ion concentration. And this is most often created by either increased production of acids or decreased restriction of acid or loss of bicarbonate. The ability of the kidney to excrete an increased acid load generally begins 12 to 24 hours after the compensatory hyperventilation begins and continues at least for 1 to 3 days. The severity of acidosis always depends on the rapidity of bicarbonate loss and the ability of the kidney to replenish the same. And patient outcome always depends upon the nature of the kidney process, disease process that led to metabolic acidosis. Like if metabolic acidosis is secondary to infection, sepsis with dehydration, if we are able to correct dehydration and sepsis with antibiotics, obviously we can treat metabolic acidosis properly. If metabolic acidosis is secondary to imbalance of metabolism, is quite difficult to treat. With this, I will hand over this to Dr. Muthiah Periyakaruppan for the next lecture. He is going to talk about kidney-specific fluid therapy. He is a consultant pediatric intensivist in Advanced Pediatric Critical Care Center, Dr. Mehta Hospital, Chennai. His specific academic interests are non-invasive ventilation, cardiopulmonary interactions, point-of-care ultrasound in critical care, and fluid therapy. Please, Dr. Muthiah.
Thank you, sir. Thank you for the introduction. So, I start with this slide. Good evening, all from Chennai here. So, I'm going to talk for the next 30 to 40 minutes on fluids in critically ill children. Are we protecting the kidney? So the disclaimer is I am not a nephrologist. So I'm going to talk from ICU perspective regarding acute care nephrology. So here in this picture summarizes the talk. On the left side, we have the river Kaveri, where the water is flowing inside the river. And the right side, we have the Chennai rainy season in Chennai, where the water is on the roads. So you know what we want. So the history of fluid therapy started in 1832 with Thomas Latte injecting saline for what he called it as blue cholera or malignant cholera. He saw life coming back after instilling saline into the patient. Later, after 50 years, Ringer's solution was identified. Then came hamburger experiments and subsequently normal saline, 0.9% normal saline, which we're using today. And later the Hartmann's Ringer's lactate. And 1941, the natural human albumin was discovered. And in 1957, we got the holiday cigar maintenance formula used in children even up to today. 1964, there was ORS discovery in Dhaka to manage cholera. And 1970s, the synthetic colloids came into role with a big, with a big boom, with namely the dextran, HES, and gelatin-based components. And 1990s, the researchers like Rivers, Joe Carcillo, Emmanuel Rivers, and Joe Carcillo did various studies, and they named it as early goal-directed therapies in sepsis, and they laid the basics for fluid resuscitation in sepsis. Then here in tropical countries, we had this dengue shock syndrome protocols. Then PALS, pediatric acute life support, training was conducted in a big way in India from that time. But after 2000s, what we understood after EGDT and everything, the ill effects of fluid, and that was demonstrated by the FEAST trial, and later on by other trials like FACT. Right? So fluid was found as an elixir, but too much of anything is harmful. So that's what our current understanding is. So the overview we'll be discussing the kinetics of fluid, the role of kidney in critical illness, the physiology, principles of fluid therapy in ICU, the intra-patient dynamicities during various phases of illness, the famous 4Ds, drug of the fluid is a drug, isn't it? So it's drug, dose of fluid, duration, and de-escalation protocols. Renal protective fluid strategies, which I'll be discussing briefly, and some condition-specific fluid plan. So fluids are cornerstone in shock management. We all know that. And we have won the battle in dengue, septic shock, cholera, trauma. But anything in excess is poison. So the goals should be is giving maintenance fluid in hospitalized patients to prevent starvation ketosis, to optimize the hydration status, to normalize perfusion, to replace their ongoing losses, and reduce or prevent fluid overload state. So how to strike the balance? We need to know the indications, and we have to properly monitor the positive and negative effects of fluids. As fluids are daily business in ICU, there is potential harm with using wrong type, high quantity, or wrong timing. So we need to understand our fluids and the difference between fluid administration in well and sick children. Fluids and kidney is like, inseparable friends. In Tamil, we call kidney as a small bag, siriniragam. So, small water bag. So it is like so related. Critically ill children have different needs with dynamic issues through the course, and the macro circulation or other organ needs may not always sync with renal issues or needs. And as the famous karma thing goes, what goes in the fluid has to come out through the kidneys. So the AKA and fluid overload is a silent killer in critically ill children, which we are aware of. So some physiology, the governing factors of fluid movement in body, famous Starling forces, tells us that there is a net positive or outward hydrostatic pressure in the arterioles, which push the fluid to the interstitial space, to the capillaries, to the tissues. They get perfused, and in the post-capillary venules, we have this net negative oncotic pressure, which pulls the fluid back into the intravascular space. And they are governed by various factors, as we know. And this determines the net filtration force. And if it is exceeds, and if this filtration force exceeds the lymphatic capacity of the lymphatic drainage, like in conditions of more overload, fluid overload, distributive shock conditions, leaky capillaries, low cardiac output states, there is interstitial edema, and this causes decreased arterial perfusion. Although the renal artery blood flow may be normal, the end perfusion to the glomerulus may be low. Decreased venous return, decreased tissue oxygenation, tissue hypoxia local to the nephrons. So the most important factor told here is the venous return. Again, the renal blood flow is governed by the autoregulation, the filtration forces, the local neurohormonal, like govern the filtration in the kidney. So normally what happens is the autoregulation thing maintains the renal blood flow fairly between a range of BP. The renal perfusion is maintained. But in conditions where autoregulation is lost, like late sepsis or something, where there is a linear relationship. As the blood pressure reduces, the renal blood flow also reduces. This is harmful. And another major problem with kidneys is they, with a stress or something, there is a baseline GFR which kind of goes up. The kidney tries to push. There is a reserve, a functional reserve, and there is a stress GFR which increases and maintains the filtration function of kidney. Thereby, the creatinine doesn't go up, and the urine output is kind of maintained to till a certain stage, up to at least 50% of the functioning nephron mass. And after that, only the urine output decreases and the serum creat goes up. So we tend to identify AKI here, but actually the actual insult happens a long time ago, which is difficult to identify without biomarkers at present stage. So diagnosing becomes late with the routine markers. That's what I want to highlight here. And the local neurohormonal factors, like in cases of low albumin states, fluid overload, congestive heart failure, or reduced renal mass, there is efferent vasoconstriction, which maintains the GFR by efferent vasoconstriction. And again, with factors like increased nitric oxide, histamine, ACI, there is efferent vasodilatation, which reduces GFR, which reduces the filtration fraction. And conditions like hypertension, hyperchloremia causes afferent vasoconstriction, thereby reducing the filtration fraction. So many factors govern the net GFR, which makes it complicated for us to understand exactly what is going on. So the next thing is the renal blood flow versus the perfusion pressure. Abdominal perfusion pressure is called as the extrinsic compression, which causes extrinsic compression due to the formula is mean arterial pressure minus the intra-abdominal pressure. And the target is kept 50 to 60 millimeter of mercury. And the renal perfusion pressure, which we are more interested is mean arterial pressure minus the central venous pressure. And this causes high CVP, causes congestion, and causes what is called as a retrograde AKI. So here we can see two examples of where mean arterial pressure is 70, when CVP is 10, the perfusion pressure is still 60. But with the near level of 65, not much difference in map, right? But when the CVP is high, there is high congestion and retrograde back pressure, and the perfusion pressure drops to 40, which is harmful. So we focus on these macro parameters or upstream markers like MAP, but what is happening at the tissue level, we are not sure. So these are important to be identified and treated when there is problem with perfusion. So if we able to answer these 4 questions, the 4 indications and 4 phases and 4 Ds of fluid therapy, we are done. So what are the questions? When to start the fluids, when to stop the fluids, like when the patient is at least half full or 3/4 full, we don't know. When to start removal, again, big question. Will the patient tolerate? There are so many questions in ICU which we discuss day to day. And when to stop the removal, this again is important to prevent the 4th hit or very rarely we see that. The timing of fluid initiation, the type of fluid, the dose of fluid, the quantity, the quality, the combination, like the combination of crystalloids, colloids, and sometimes, the fluids and nutrition, everything is important. They all govern. The indications of fluid in critically ill children is for resuscitation, for replacing the ongoing losses, for maintenance fluid therapy when they are kept NPO, to maintain glucose and electrolyte balances, and as a nutrition source. The 4 phases of fluid therapy, the famous ROSC concept, which tells the patient travels, any sick child travels through these phases, like resuscitation, which happens in the first phase, or it's called as the first hit, which happens because of the primary disease state of the child, which goes on for minutes to hours. Then the optimization, when we post resuscitation, we kind of, this is the hypovolemic state, and here we have the ischemic reperfusion injury, or the second hit phase, which lasts from hours to few days, where we try to optimize the organ function and stabilize the organ function. We support the organ function, and through this phase, we go through from ebb phase to the flow phase, when the patient becomes fluid positive. The cumulative fluid balance becomes positive. And here you can see from the second phase, we try to maintain conservative fluid balance, not to increase too much. And later, once the patient is coming out of the critical illness, when the primary disease is settling, we go to the evacuation phase, where we try to remove fluids and try to maintain negative balance, which happens over the next few days to a week. And when we overdo, we can have a 4th hit, which is called as the later, which is because of the more fluid removal. And similarly, overlappingly, we have the organ failure stages. In the first phase, there is severe organ failure, MODS, and then slowly the multiple organ dysfunction improves and the patient gets better. And then again, he can have a 3rd hit because of the, we call it GIPS, Global Interstitial Permeability Syndrome, like because of the fluid overload, because of the later leaky phase, which happens in the later phase or secondary hit. And again, there can be organ function failure and later on recovery. So what we want to avoid is the secondary hit, which happens here. So in the first phase, we try to save life. Second phase, we try to rescue the organs and support them, and then recovery. So the most important thing is here there is inflammatory insult in the first phase, then ischemic reperfusion injuries, and the 3rd hit is the GIPS, which I told you before. And here we give a lot of fluid boluses and the patient is fluid positive. And here we try to maintain neutral balance. And in the 3rd phase, we try to make the patient neutral to slightly negative, and 4th phase, we don't want any positive balance. The 2nd and 3rd phase is called as zero balance phases. We try to maintain neutrality. And the risk in the first phase is insufficient resuscitation if we underdo. And the later phases, what if we overdo? So coming into the type, dose, and rate of fluids, whether do we give crystalloids or colloids, whether we give isotonic or hypotonic or hypertonic fluids, or do we give colloids, whether we give synthetic or human albumin, or when to give blood products or other plasma expanders, what is the role of fluid bolus, how fast to give, how much to give, the fluid responsiveness, which I try to answer in the next 10 to 15 minutes. So the toxic dose of fluid, we must know, the speed with which we have to give the bolus, the daily needs have to be satisfied, the kinetics and dynamics of the fluid need to be understood, the appropriate duration for which the fluid has to be continued. And here we talk about cumulative dose, not the daily fluid positive balance, it's the cumulative fluid positivity. And treat for response, not to just chase some numbers. We try to monitor the ill effects of fluid, and we identify non-responders during the course and stop fluid therapy in them, and we de-escalate as soon as possible. So this is an important slide done by Han et al., their work in pharmacokinetics and dynamics of fluids. So again, we can see the first top one tells us how the fluid behaves differently in different disease states. Like the same 2 liter RL was given in all these patients. The topmost one is the hypovolemic shock. After giving 1 liter, after giving 2 liter, almost 1.6 liter is retained. Whereas in post-anesthesia induction, only 1.3 liter was retained. And in healthy volunteers, hardly 500 ml was retained. So this is good. In hypovolemic states, and we tend to retain more fluid in shock states, which is good in the intravascular space. What about the type of, this is what the body does to the fluid, and what the drug, the kinetics, what happens to the type of, based on the type of fluid. That is the second one, where whether we give colloids or crystalloids. The first one, the topmost one, is the expansion response after quick 20-minute 1 liter bolus of colloid, and the second, when almost everything is retained and slowly it falls at the end of 1 hour. And the second one is when we give ringer lactate, almost 700 ml is 3/4 is retained, and it quickly falls at the end of 1 hour. The intravascular retention I'm talking about, plasma. And the third one is when we use 5% hypotonic dextrose, hardly anything is retained. So here, from this one, it seems colloid is very attractive, but is it the real case? And the third one is the rate at which we give the fluids. The infusion, when we give it over, like the first one, the red one is when we give colloids, and when we give the dotted line is the crystalloids. When we give it over 30 minutes, the red one, and the black one is when we give it over 1 hour, and the blue one is when we're giving it over 3 hours, the same fluid. The solid lines are the colloids, and the dotted lines are crystalloids. So colloids and crystalloids do fairly same, almost similar, when we give it over 30 minutes to 1 hour duration. So currently we are practicing this 30 minutes to 1 hour duration, the fluid bolus. And again, the colloids used here was 10 ml per kg, and the crystalloids used were 20 ml per kg. So we again found out that almost the requirement halves, or even further, like 1/3 of requirement is there for colloids to get the same response as crystalloids. And when we give it over prolonged duration, over 3 hours, there is no much retention. So from these studies, we are able to understand the rate at which we have to give the bolus and the type of fluid which has to be started initially and then later on. I think I've made the point clear. This is a very important and useful slide to understand, actually. And so we know, what about the tonicity of fluids? If we give hypotonic fluid, at the end of the day, what we want is we want to keep more fluid inside the intravascular space and less in the interstitial fluid, and not in the intercellular, and we don't want to disturb the intercellular space. But when we use hypotonic fluids, there is cellular edema, and that causes problems. So what about hypertonic fluid? We can give less volume and get more intravascular volume. No. Then also we are at risk of cellular dehydration, and this hyperosmolar load to the kidneys can cause further AKI. So 3% saline and all those things are not used routinely in shock. So our stay of management is predominantly isotonic isoosmolar fluids as of now. So the quantitative toxicity which we're talking about when we use routinely the crystalloids and colloids which we use is is mainly identified from the FEAST trial. The FEAST trial is fluid expansion as a supportive therapy trial, which was a landmark trial done by Catherine Maitland in sub-Saharan Africa with children who presented to ER with hypotensive or shock, signs of shock in resource-limited settings. And they randomized children into 3 groups, one group receiving no bolus, one group receiving only saline bolus, the other group receiving the albumin bolus to the tune of 40 ml per kg over 1 hour. And their primary outcome was mortality at 48 hours and at the end of 4 weeks. So to the surprise, everyone who received, children who received no bolus had a 3% mortality benefit compared to the saline and albumin group, which fared similar in mortality. And even when they did the subgroup analysis, to everyone's surprise, whether there was malaria in the background, whether there was low hemoglobin or high hemoglobin, whether there was high lactate or low lactate, or acidosis or not, in all cases, fluid bolus was harmful. So the study was stopped and they published the data telling fluid is harmful. And it was a fairly well-designed study. So how does this happen? That's again important. So knowing again the ill effects of quantitative toxicity of fluids, 40 ml per kg, 60 ml per kg, which we were talking about, was harmful. And again, whether to give crystalloids or colloids, that's the next question, right? the colloids are supposed to retain better than crystalloids, but in clinical real implication, is it so? But in real practice, it's not colloids versus crystalloids. It is crystalloids alone or crystalloids with colloids. So because we hardly use colloids in alone in real practice, right? We try crystalloids first in shock, and then only we go for colloids. Colloids alone is used only in trials, controlled trials for comparison. So this what next? We know that too much of fluid is harmful. Too quick fluid is also harmful. What about the type of fluid? Is there any difference in harm? The qualitative toxicity. So whether colloids are safer or harmful, whether balanced salt solution are harmful or safe. So that is the next question. So these are the trials, the famous trials, the saline versus albumin study, the HES studies at various multi-center places, then the recent albios, albumin in severe sepsis study. All of them, they found out only one thing, that there is no much difference between colloids and crystalloids. As far as types of synthetic colloids are concerned, the dextran is almost out of context now because of allergy and renal failure. The 6% HES, hydroxyethyl starch, is also out of context because of allergy, more inflammation. It's not useful for sepsis. It causes hemolysis, renal failure. But a subgroup analysis showed it was benefiting in polytrauma cases in these studies. And the gelatin is relatively safer, but it's less efficacious and not used very commonly except in dengue shock syndrome in our part of the world. And the albumin, as far as albumin is concerned, the studies showed there was no difference in it is equally safe. The outcomes, the resolution of shock, the mortality benefit was all similar. There was no difference in AKI incidence, RRT, mechanical ventilation duration between the saline, between the crystalloids and the colloids group. And the problem with the high oncotic load, we need to be cautious in AKI situations in the background of lung or heart disease, and it should not be used. Albumin is not useful in, a subgroup analysis should not be used in traumatic brain injury, but it is relatively safe when the patient is at risk or at having an established AKI, to the contrary of the previous thoughts. Benefit in specific subgroups is noticed when there is sepsis with low albumin, like nephrotic syndrome, or burns when there is a fluid creep, more than 20-30% burns, post-cardiopulmonary bypass when there is low albumin status, hepatorenal syndrome, and other third spacing situations. And 20% albumin is rarely used for resuscitation. It's used as a protein supplementation. So coming to the balanced salt, next hot topic, balanced salt solution. The chloride, we have to discuss about chloride here. It's the main extracellular anion contributing to 1/3 of plasma tonicity after sodium. The problem is it can activate the immune system and it's pro-inflammatory. It causes renal dysfunction when it's in excess. It causes afferent vasoconstriction, afferent arterial vasoconstriction, and reduces GFR and causes coagulation abnormalities. So any patient who's developing new acidosis after resuscitation, we have to suspect hyperchloremic acidosis. This is a non-anion gap acidosis. And especially after large volumes of crystalloid or 5% albumin resuscitation, there is more this kind of metabolic acidosis, especially in children who are having pre-existing AKI, which is common. And it's often under-recognized and poorly managed, and it is managed as shock. And the base deficit is very high in these patients, and that becomes a key prognostic tool in pediatric mortality risk scores. So it's because of the strong ion difference, the Stewart concept, which tells as the chloride increases, the strong ion decreases. It's based on the total anions is equal to the number of total cations in the body, and the gap is supposed to be normally 40, and when it reduces, it contributes to acidosis. And here we tell about the chloride versus sodium ratio. Normally in plasma it is 1:1, but in normal saline it is 154 is the chloride against the 100 of plasma. So it is 1.5:1. So the chloride loading happens, and that causes a decreased the strong ion gap and causes acidosis. What about the studies? The balanced salt solution, the famous SMART study, the salted study, all the adult large sample multicentric studies showed in adults that balanced salt solution had a lower rate of composite outcome of death from any cause, new RRT initiation, and persistent renal dysfunction, which is better than the use of saline in these groups. But what about pediatrics? There is no much studies. There is this one SPINK trial from PGH Chandigarh where it's a single center small sample size where they have studied saline versus plasma light in DKA children, and they found out again, in DKA, we give a lot of fluids, right? A lot of fluids. So it's a valid study, basically. The incidence of, the conclusion was the incidence of new or progressive acute kidney injury and resolution of AKI were similar in both groups. And the time to resolution of DKA, need for RRT, mortality, and length of PICU and hospital stay were similar in both groups. So for children, I think we can start with anything because of the cost factor. In resource limited settings, we can use normal saline first and then monitor chloride and then decide on other parameters like AKI setting in and all those things and decide on balanced salt solution later on. So this is the summary of all the fluids which are available, the huge basket. This volulite, voluven, and all are HES which are hardly used. The gelofuscin and hemaxil are gelatin based which are rarely used, and the other ones are commonly used. So what about the other organ dysfunction and kidney? The common one is the cardiac dysfunction. When there is LV dysfunction, there is high LV filling pressure with low cardiac output, arterial underfilling, and the renin-angiotensin system is activated, and there is decreased and there is vasoconstriction and decreased perfusion pressure. And when there is right heart failure or back pressure, increased venous return, increased preload, there is venous congestion. That again activates the kallikrein and the natriuretic peptide system, thereby causing increased venous pressure and decreased perfusion pressure overall, thereby contributing to AKI. And in these patients with impaired renal auto regulation and there is high susceptibility to AKI per se, this susceptibility with the insult puts them at great risk for tubular interstitial damage, and then followed by a tubular with the onset of AKI that goes into a persistent tubular damage and then goes on to AKD and then CKD, in fact. And again, the management window narrows down. When we have a normal heart and a normal kidney, you can see the management window of fluids is quite liberal. But when there is a diseased heart or a diseased at-risk kidneys, the management window of fluid narrows. So it becomes more difficult to manage them in both the extremes. So this is the U pendulum, which I was talking about, the hypovolemic on one side and the hypervolemia on the other side. So in hypovolemic states, we know albumin, buffered salt solution, isotonic saline are good. And in euvolemic state, we should be careful not to overload the patient at this state. So any shock, we need to do what is the fluid responsiveness test and then give fluids cautiously. And in hypervolemia stage, we try to remove fluids with diuretics or albumin when there is low, or consider RRT, early RRT also in these overloaded patients, because then we can't do much. So the responders, only hardly the difference between responders 50, only 50% of the fluid ICU patients respond to fluid challenge. So 50% of the patients don't respond to fluid because of their primary pathology. So this is in contrary to the statement at least give 30 ml per kg. No, some patients even don't tolerate 10 ml per kg of fluid bolus. So we need to tailor fluids to individual pathology and individual needs and assess fluid responsiveness whenever possible. And any child with a leaky state developing interstitial edema post fluid bolus, which can be assessed clinically by a lung ultrasound with increased B lines or increasing effusion, they are considered non-responders for all practical purposes. And post-operative, but the difference is the post-operative state, when the patient has received a graft or a post-transplant, a solid organ transplant, or a BMT, when we try to maintain positive balance. And post-abdominal surgery, again, prothrombotic states, we try to keep them more positive. And we have to be cautious with CKD and cardiac patients because even trivial positivity matters in them. So here you can see the increasing the preload. This is the superimposition of Frank-Starling curve and the cardiac output curve. Like on increasing the venous return or preload, normally if the cardiac output improves, then we call positive inotropic effect. But in a different patient who is having a cardiac disease or a AKI or a CKD, the increasing preload may in fact push the heart down. So we need to be careful about giving fluids. This is similar superimposition of multiple curves. Like you can see, in this case, we are increasing the preload from left to right, and the cardiac output is on the y-axis. And we can see what we want is ideally the black dot point. And we want to operate on the steep portion of the Frank-Starling curve. But sometimes giving more fluid in this child is harmful compared to this child. This child, the lower curve requires more inotropic support, and the child who's here, this lowermost blue line requires more fluids. So to identify them identifying the clinical phenotype is important. So again, this is by famous researcher Paul Maverick, where we can see the preload challenge here gets a very good cardiac output response in the y-axis, whereas here giving this much of similar amount of preload causes very less change in cardiac output, where when the patient is in the plateau phase of the Frank-Starling curve. And in fact, here there is more risk of extravascular lung water and lung flooding. And similarly, different cardiac output, LV contractility function, there is different response to preload. Like in these patients, top curves, preload has a good response, whereas in the bottom curves, giving preload in poor LV function is harmful. So always before giving a preload, we need to check fluid responsiveness. Coming to this fluid responsiveness, when there is a clear-cut acute circulatory failure, low blood pressure and cardiac output, signs of tissue hypoperfusion is obvious, you can very well give a fluid bolus. But if not, when you don't know whether the fluid loss is significant or not, when the patient is not in the initial phase of septic shock, we need to consider fluid bolus, fluid responsiveness test, preload responsiveness test, which is different in spontaneous breathing and ventilated patients. I'm not going to go into details. But after that, if it is positive, you can consider volume expansion based on the risk of fluid overload. But if not, if they don't respond to preload responsiveness test, you don't give fluids to them. Again, in ventilated patients, clinical context is very important. And if there is an initial phase of hypovolemic shock, or you know that there is a clear-cut fluid loss, you can give fluids. Otherwise, you need to do the fluid responsiveness. And if there is benefit more than risk, then you consider fluids. Otherwise, you consider other therapies of fluid removal. And again, here in ventilated patients, you check fluid responsiveness to guide fluid removal too. Like you do a passive leg raise test to check the fluid unresponsiveness. If there is no cardiac output rise or improvement in BP or other things after doing a fluid responsiveness, then this patient is not going to respond to fluids, and in fact he'll get better with removing fluids. So with sepsis, it's a different thing. Early phases there is hypoperfusion due to vasoplasia. Later on there is ischemic hypoxic damage to the tubules, leading to, and also the cardiac output reduces, which causes hypoperfusion in the later phases. So improving macrocirculation post-bolus improves the renal artery blood flow, but doesn't improve the glomerular perfusion. And in fact, by giving more fluid, we're going to cause more filtration work to the already tired kidney. And it further worsens occasionally by our hemodilution and edema. And here again, sepsis-induced endotheliopathy is important. Causing this endotheliopathy causes microvascular thrombosis, leak, and glycocalyx injury, causing more inflammation and cellular infiltration. So how to identify, the kidney damage? Not by macro numbers. It's by biomarkers, urine output, and sublingual microcirculation. That correlates to kidney injury. That's what study says. The shock-induced endotheliopathy, the SHINE, which tells us about the endothelial damage. As the endothelial damage worsens, the microvascular dysfunction worsens and the microcirculatory failure ensues. So in the initial phases of shock, we go through the as nephrologists, you people will be knowing more convection and diffusion. So there is an initial convection problem, taking the fluid to the tissues. But later on, the fluid is reaching the tissues, but not able to diffuse through the tissues, through the interstitial space because of the interstitial edema, because of the glycocalyx damage and the endotheliopathy. So this understanding is important because the altered Starling forces. This was recently identified. The original Starling forces didn't discuss about this. There was interstitial excess after fluid administration, further leading to lung flooding, tissue hypoxia, then contributing to more MODS. Again, the lung-kidney dilemma is like intensivist nephrologist dilemma, whether to give more fluids or remove fluids. Always the kidney and lung, we hope they function together, but they don't function so. So coming to the most final touch on fluid overload. So many studies have been done after 2000 and famous by the Stuart Goldstein study, where they found more than 10% fluid overload is associated with high mortality. So initiation of RRT is prescribed above this level, and the fact and it holds on to the FACT study also, which are adult studies basically, and the Goldstein study is the children one. And what happened to the kidney in fluid overload? There is renal interstitial edema, there is increased renal venous pressure, there is decreased renal blood flow, and because of that, there is low GFR, high renal vascular resistance, and salt and water retention and uremia. You can see like a jammed road because of flooding. The vehicles are not able to move properly, right? This is what happens in that. And again, we can monitor fluid overload by tools like intake output balance, body weight, and now more numerically by bioimpedance testing and ICON. We have so many things to check the total fluid, thoracic fluid content and everything, but nothing is foolproof. So what happens is this vicious cycle. When we resuscitate the patient, they in the leaky phase they develop edema and organomegaly, and they have intra-abdominal hypertension causing abdominal perfusion pressure to decrease and renal perfusion pressure to go down, causing oliguria, which again mandates, which again blindly we can do fluid resuscitation. And again, intra-abdominal hypertension causes venous compression and venous hypertension, which again mandates fluid resuscitation because of the hypoperfusion signs. So any patient who is requiring all these things in the capillary leaky phase, there is more edema, third spacing, and this contributes to more abdominal hypertension. And this clinically seen as more hypoperfusion, more ventilation problems, more hypoxia, leading to more ischemia. And this is a vicious cycle which goes on and on unless we do something about it. So this is the overview. And the last 5 minutes, I'd like to discuss some fluid decision making in common clinical scenarios before winding up. A 6-month-old infant with history of diarrhea, vomiting, multiple episodes of vomiting last 3 days, presented with shock and no peripheral pulses. So here the blood gas shows a pH of 7.05 and bicarb of 4, lactate is 3, and there is no urine in the last 12 hours. So this is a classical garden variety AG with severe dehydration, hypovolemic shock. You just have to give a lot of fluids, crystalloids preferred, and there is no role of bicarb. Coming to the next scenario, a 5-year-old child, male child with day 6 of fever, received already 3 fluid boluses initially for shock, 10 ml per kg, had hypoperfusion signs, was started on inotrope, adrenaline low dose with active third spacing, having low urine output since last 6 hours, 0.6 ml per kg per hour, is like having a 4% positivity in the last 24 hours, but urea create is fairly okay for his age and weight, is currently receiving 100% maintenance fluid. This is a severe dengue child who's having signs of AKI. So what is the fluid plan for him? Here you can see the patient has already received some fluids and he's in the critical phase, he's leaky. We can't give more and more crystalloids as he's having third spacing, active third spacing. Actually, the third spacing is actually interstitial edema, nothing but interstitial edema. So here giving more fluids is harmful and giving boluses is really harmful. So we have to go on, switch over to colloids because the retainability of colloids is better. And we know we have to just glide through 2 or 3 days through the critical phase. So giving colloids may be beneficial. And in fact, a part of the maintenance fluid can be colloids to prevent further overloading of patient. And the next case is a 10-year-old known case of nephrotic syndrome who was a frequent relapser on oral steroid therapy, presenting with features of septic shock, probably a gut focus, having vitals, unstable vitals with tachycardia, low BP, altered sensorium. He's fluid responsive initially. He's given 30 ml per kg, but has an ill-sustained response. He's intubated for shock and he's on infusion of inotropes of adrenaline, noradrenaline, moderate doses. And there is an AKI in a pre-existing kidney disease patient. Urea is elevated, creatinine is high, and there is low urine output for the last 6 hours. So this is a scenario of septic shock with AKI. So now what to do? Whether to give more fluids or what? So here the clue is, I have not given in the scenario, is what is the albumin level. So if the albumin level is low, like in this case it was 1.5 gram, we can supplement 5% albumin quickly, or even 20% albumin for that scenario to boost the albumin level, and it's found to have a good response. In fact, this patient didn't require RRT, the inotropic requirement subsequently came down after using albumin, and the urine output picked up. The next is a 1-year-old child. This is again not a common scenario for a general PICU patient, but a 1-year-old child post cardiac surgery, intracardiac repair for tetralogy of Fallot, day 1 post-op, is on inotropes like adrenaline, milrinone infusion, and is on mechanical ventilation, having ejection fraction of 60% with some RV dysfunction. The vitals are like this: heart rate 140, BP is fairly normal, CVP is 15. Investigations revealed all normal, blood gas, lactate all normal, but there is elevation of transaminases. There is the urea rate is normal to start with. The drains output, everything is normal. Drain output, the blood loss is not much. Hemoglobin is okay, 12 compared to a pre-op of 15. Coagulation profile normal, but he's having low urine output the last 4 hours. So what do you do? Post-op cardiac surgery with AKI having an RV failure. So here the fluid strategy is a little tricky. The CVP is high, but in a post-RV surgery with a stiff RV, you tend to give more fluids initially to maintain the preload, because and you try to maintain a higher CVP, but that is only for the first 12 to 24 hours. Because giving more fluids will cause more, back pressure, more congestion, these are all congestive problems, the transaminases, the urine output coming down. So here it's predominantly, giving more inotropic support and early diuretics after the crossing through the first 12 to 24 hours, giving fluids at the same time removing them simultaneously. Otherwise, the patient can go for it's like taking the blood from the right side to the left side. That's what we commonly say. Do something to take the blood from the right heart to the left heart by giving some fluids, managing with inotropy, some afterload reduction, and then perfusing, maintaining the renal perfusion pressure. That's the goal of management. So giving some fluids, but at the same time, caution. Next scenario is a 3-year-old child admitted with severe pneumonia, intubated for respiratory failure, subsequently developed AKI with 24 hours of admission. Within 24 hours of admission, there is oliguria, creatinine doubling, is fluid non-responsive, subsequently developed fluid overload with increasing ventilator settings. The SpO2 reduced with recurring high FiO2. BP is borderline on adrenaline infusion. So this is a very complex ICU case who is having severe ARDS with AKI as a part of MODS. So what do? Here, definitely more fluids are harmful. Diuretics can't be given because of the BP and other problems. He is oliguric and creatinine is doubled. So here, only the one thing what we have to do is the initiation of early CRRT, probably continuous because of the hemodynamic instability, either CRRT or PD based on the availability, or SLED maybe. And based on the tolerability, we can remove the fluids. And tolerability, the goals of removal is generally not is about 20 to 25 ml per kg per day. We don't overzealously remove more as we are worried about the third hit. So although the patient is very much overloaded, we have to go a little slow based on the tolerability, and we generally target 2 to 2.5%, not more than 2 to 2.5% negative per day in these patients based on the tolerability. And in fact, these patients fairly do well after removing fluids because the hypoxia gets better, the reactive oxygen, the inflammatory storm reduces, putting them on RRT, and then the perfusion, renal perfusion, in fact, improves. So the native kidney output also improves, and the BP is also better maintained. We think contrary on putting on extracorporeal, we're going to remove more fluid, more blood outside, but actually other thing happens when we start them timely, in a timely fashion. The last case, the case is the 6-year-old child with a solitary kidney with colicky abdominal pain, anuric for last 24 hours, and having a high urea and creatinine. He's having a calculi which was diagnosed and removed ureteroscopically with a DJ stent in situ. Electrolytes are normal, urea create is falling trend. The status post-op in ICU is last 12 hours is polyuric, passing 8 ml per kg per hour. So this is the post-obstructive AKI. And here there's a pathological diuresis. What is pathological? Usually we expect some diuresis after relieving obstruction, but when there is a secondary nephrogenic diabetes, DI, which you might be more familiar, there is pathological diuresis associated with signs of hypovolemia. Here we need to supplement some fluids, and we need to discuss on maximum replacement, not more than 150% of the maintenance per day. And beyond that, it is harmful again. A last case is a 12-year-old child who is having a TALL, start on chemotherapy, 24 hours post-chemotherapy is being monitored for TLS, developing TLS features. Uric acid is 8, phosphorus is 6, and calcium is 7, but having fairly normal, slightly elevated renal parameters. Urine output is okay. For the last 6 hours, it's 1.2 ml per kg per hour. He's received allopurinol and rasburicase for the same. This is TLS with starting of AKI. Here the fluid plan is, we need to give more fluid. 3,000 ml per meter square is if the patient is tolerating, we give 3,000 up to 3,000 ml per meter square, and the target is we target at least 2 to 3 ml per kg per hour urine output to prevent cast formation in the tubules. And the role of Lasix is there. If the patient is fluid overloaded, maybe we can give a little low dose Lasix infusion to flush off the kidneys, and RRT if medical management fails. And the polyuric AKI is also an entity where the patient is polyuric, like in this case, urine output is okay, but they can develop at risk of AKI. This is commonly seen with diabetic ketoacidosis, burns, rhabdomyolysis due to causing pigment hematuria because of that, high CPK and cast in the tubules, and diabetes insipidus. These can cause polyuric AKI. These are the scenarios. So to conclude this session, IV fluid is a drug, and the right fluid, the right type, volume, and rate is important and to be given, and for the right time for the right patient. Fluid stewardship is what we have to follow with bundles and educating our team. This as a good outcome in reducing AKI, the length of ICU stay, length of ventilation duration, early weaning is possible, and electrolyte imbalances can be minimized. And post-resuscitation phase, we want a dry patient in ICU, not a dead one. So do's I just whenever we have fluid when we're giving For intravascular hypovolemia, we can give fluids, and we prefer crystalloids, and we prefer boluses of small liquids, and only until hypovolemia is corrected, not until AKA resolves. Thank you. We have done so many studies in various phases of fluid resuscitation. Still, there are so many unanswered questions. Thank you. Thank you for your listening. And I'd like to thank IPNA for giving this platform.
Thank you, Dr. Muthiah. It's a very nice, in-detail lecture. And now I would like to invite Dr. Ravikumar. And he's going to give a lecture on metabolic acidosis in sick children. He's a senior pediatric intensivist working in Dr. Yala Institute of Medical Center. He has done his fellowship in pediatric critical care from sick kids. His specific academic interests are pediatric transplant ICU, extracorporeal life support, and mechanical assist device, pediatric transport medicine. And he received the gold medals in undergraduation, post-graduation. Yeah. I'll hand over to Dr. Ravikumar. Please go ahead.
Yes. Thank you for the opportunity, and I thank IPNA and Dr. Kalabani for giving the opportunity. Thank you, Dr. Satya Prasad, for introducing. So before I start, this is my institute, and I'm going to talk about metabolic acidosis in critical care. To go about, we'll just try to rush through the basics about it, of the acid-base balance. Basically, around 15,000 millimoles of carbon dioxide, which is your volatile gas, which is being removed by your lung, are being produced every day. Around 50 to 100 milliequivalents of non-volatile acids are produced each day, which is your cause for your metabolic acidosis or your metabolic imbalances. And the acid-base imbalances are managed by the kidney and lung. And lung is a rapid one to respond to whenever there is acid-base imbalance, and kidney takes a longer time. When I talk about these things, we need to know some basic knowledge about it. The kidney excretes the non-volatile acids either by removing the hydrogen ion with titratable acids like phosphates or ammonia. So acids are, in the basic knowledge, acid is something which gives hydrogen ion on dissolving into any soluble solution. That's the beginning of thought process. And we'll see how our thought process about acid-base balance went about. When we thought about in water, and when we thought about in our plasma especially, the major acid production is your volatile acids, which are carbon dioxide, and non-volatile metabolic acidosis, which I talked about the other acids which we produce. And a major buffering system. What is a buffer? Buffer is something which, when acid or a base is added to the solution, it tries to bring back the solution to the near normal physiological pH. The most commonest and the major buffering system in our body is your bicarbonate and carbonic acid buffering system. And based on this in the water, and we add this equation, which came as your Anderson Esselbach equation, which talks about the reactions related to the ratio of your bicarbonate and your carbon dioxide. But our body has not, the drawbacks of this Anderson Esselbach reaction is, it is very good in explaining when it comes to the respiratory part of your acid-base balance. When it comes to the metabolic side, it doesn't say about the severity and doesn't account for the other metabolic anions or the acids which are produced in the body. That is explained in the isohydric principle, where it is not just your carbonic acid and bicarbonate, even your phosphates and albumins, which also are being balanced by the hydrogen ions. So with this thought process, we had to go forward and, Then came the thought process by stewards who talked about the strong ion difference. I think Muthiah touched in a small amount about it. It is in a plasma, the electronuclearity tries to maintain the cations and anions equally. And strong ions are something which can dissociate freely in water or in a fluid, and it has a weak affinity for conjugating. And our body has equal amount of it. And based on this, our acid-base balance is explained. And there are three basic independent variables which determines your acid base, which is your partial pressure of carbon dioxide, which takes care of your respiratory component of the acid-base balance, the strong ion difference, and concentration of non-volatile weak acids. strong ion difference is normally 38 to 42, and which I will be explaining in detail as we go on. Then non-volatile weak acids present in the body or in the extracellular and the intracellular is your albumin or your proteins and your phosphates. Okay. So what is the impact of acidosis in our body? It causes actually shifting of the oxygen dissociation curve to the right. So the hemoglobin has less affinity to the oxygen, and you have a depression of the myocardial contractility and cardiac output. It has less responsive to your catecholamines. There is a risk of hyperkalemia because of intracellular the shifts which happens in the thing, and it also reduces your insulin tolerance and your immune dysfunction. This is a good graph which talks about the relationship of the pH or your acidosis to the myocardial contractility. As you see there, as the pH decreases, your myocardial contractility also decreases. What are the clinical features of acidosis? And by system-wise, in the central nervous system, it can cause headache, confusion, and loss of consciousness or coma. In the heart, as a compensation when you have metabolic acidosis or acidosis, the body responds by trying to remove the acid in the form of carbon dioxide. So you have tachypnea or silent tachypnea. In the heart, you may have myocardial dysfunction, arrhythmias, and you may feel tired and weak. So based upon your Henderson's equation and based on simple algorithm to go about, and the pH is low, you call it as acidemia, along with the increase in the hydrogen ion or decrease and hydrogen ion. And when your pH is high, you think it as alkalemia. Based upon whether your PCO2 is high or whether your bicarb is low, you divide it into respiratory acidosis or metabolic acidosis. The body tries to compensate, and as I said, for the compensation, the respiratory compensation acts earlier, and it takes only minutes to get into place, but the metabolic compensation takes a long while to reach. So as already said, the metabolic acidosis can be produced by three major mechanisms. One, either by increasing the acid generation. And the examples will be your lactic acidosis or ketoacidosis, or your toxins and drugs which can increase your acid production, or it can be because of your loss of bicarbonates, as in severe diarrhea, or in the renal tubular acidosis or urinary diversions. Or it can be because of decreased renal acid excretions. And we can find based upon the anion gap. Anion gap is basic, as I said, there's neutrality always. When you try to get a balance between your known or your ions and unmeasured ions, normally there is a gap of 8 to 12. If you take into account, without taking into account of potassium, if you take into the account of potassium, the anion gap is 16. This explains to you the unmeasured anions in the body. Based on this, you can divide the acidosis into wide anion gap metabolic acidosis and narrow metabolic anion gap metabolic acidosis. Here in wide anion gap metabolic acidosis, either you have increased acid production like your lactic acidosis or ketoacidosis, and there is a loss of bicarb or there is a loss of bicarbonate. In a normal anion gap metabolic acidosis, you have a loss of bicarbonate, or there is a decreased acid secretion with relation to the kidney, chloride secretion. We have a lot of mnemonics to remember, and most of us remember the mud piles. And basically, you need to understand it's going to be either the toxins or it's going to be because of your metabolism, which you have a wide anion gap metabolic acidosis. In narrow or your normal anion gap metabolic acidosis, the major cause here is either there is increase in serum chloride or there is a relative decrease in serum sodium, which causes narrow anion gap metabolic acidosis. Whenever you have an anion gap, we need to do a corrected anion gap. That will get is nothing but whatever anion gap you get, added to that you need to correct for the serum albumin. Albumin is also a weak ion which is unmeasured. Based upon the acid base balance by Stewards, the plasma has electroneutrality, and water, which is having both hydrogen and base, maintains an equilibrium based upon the electroneutrality. When there is a difference happens and when the electroneutrality is imbalanced, there is a chance that the water dissociates to release hydrogen ion, or it can absorb. So that's the principle for us to know about the strong ion difference, and it's called as apparent because the values which you are measuring, with that we always say all the measured cations is equal to all the unmeasured cations. Normally the value is between 38 to 42. And in a critically ill, this value, studies have shown that this value is relatively less because these patients are most of the time hypovolemia is quite common in these patients. And their respiration is tachypneic when they are sick. So their PCO2 driven loss resets the strong ion difference to 30 to 35. And if the strong ion difference is more in the form of then it causes water to dissociate in such a way that the hydrogen ions are lost, so you get alkalosis. Or when you have a narrow stand or decreased strong ion difference, you have acidosis. Based on this, you can divide the metabolic acidosis into either in a case where you have excess of unmeasured anions, or is it because of increase in chloride or a relative decrease in the sodium, or in relation to the chloride. So when you have a metabolic acidosis, we also need to know whether there is a concomitant any other metabolic, because it is always possible that you may have a mixed acidosis. Best example is when you have a Bartter syndrome. Because of hypovolemia, they may have a normal pH at times, but when you evaluate them and you have a shock or acidosis, that they may have underlying metabolic alkalosis. How to calculate is basically doing a delta ratio between anion gap and delta hydrogen bicarbonate. How to calculate a delta anion gap is whatever the patient anion gap minus your normal anion gap, and similarly whatever the patient's bicarb against the normal. When the ratios are equal, then you have only a high anion gap and normal metabolic acidosis. If the ratio is more than 2, you have an underlying metabolic alkalosis. And when I talk about metabolic acidosis, lactic acidosis is one of the most common, and it is the most important thing to be looked, because it is not only the reason. When it is more than 5, it has prognostic indications also. Normally our body produces roughly around 1 millimolar per kg of lactic acidosis per hour, and it is the mismatch which determines the lactate level in the body. As I already told, the magnitude and duration of the lactic acidosis correlates with the mortality. Liver is a very important place where the lactates are metabolized, and it takes place in 3 ways. Either it enters into the backs as glucose in the Cori cycle, or it is oxidized back to a by pyruvate dehydrogenase and it enters into the Krebs cycle, or it is converted into alanines as an amino acid. The lactate in the body are divided as type A and type B basically, and there is something called D-lactate, which is by the bacteria which are formed in the small intestine. Type A lactates are nothing but you have a tissue hypoperfusion, which may be because of hypoxemia or hypoperfusion. The best example is your shock or myocardial dysfunction, or if you have ischemic tissue. Type B is considered as non-associated tissue hypoperfusion. It can be because of increased cellular metabolism, like your burns, your SIRS, or it may be because of your toxins and drugs. Best example will be your salicylates, your alcohol, your epinephrine. Best example, when you start epinephrine in a sick patient, you have increased production of lactate. And then you have congenital deficiencies. And the final is because whenever you have a liver dysfunction, the lactate cannot be metabolized easily, so your lactate level can rise. So next kind of metabolic acidosis, which all of us have interest, is hyperchloremic metabolic acidosis in AKI. I think Dr. Muthiah also spoke in detail about it before. There are controversial studies and they have talked about it. As such, the hyperchloremic metabolic acidosis, people have found that there is a afferent arterial vasoconstriction and there is a reduction in the mean velocity of blood flow. But as it transferred into the form of AKI, studies have shown that initially by Sen in 2016, they said there is some association, but the split study or later the spring study, they did not show any correlation of difference between the balanced solution versus saline on AKI or the hyperchloremic acidosis result in the AKI. And even the same in a sick patients like a septic shock also, they did not find any difference in hyperchloremia inducing AKI. What is the effect of chronic metabolic acidosis in the body? It can cause bone resorption. It can cause muscle tiredness. It can cause fatigue because of the tachypnea. It can reduce myocardial contractility and produce heart failure, I already said, and it can cause insulin resistance, and it can actually disarrange your immune mechanism. So when study was made about to find the usage of bicarbonate at different pH, the nephrologist use was for different reasons, and for the intensivist side, they were using it for a very low pH of 6.1, 6.9 or 7. So why a bicarbonate is used? Basically, when you have a severe acidosis, we know that there is a severe myocardial dysfunction. To improve, bicarbonate was used, and the formula which is used is based upon the base deficit. And it also causes arterial vasoconstriction, and it also improves the catechol response. These potential side effects is there intracellular acidosis when it happens, because as soon as you give a bicarbonate solution, as per your equation, the curve moves towards the left side in such a way that carbon dioxide is produced, which may enter into the cell and cause intracellular acidosis. So when you give a bicarbonate, remember that we need to have a good ventilation, because otherwise there is a chance that you have a severe acidosis worsening. Again, it accelerates the lactate production. It may cause a shift in the drop in the ionized calcium. Apart from bicarbonate, it can causing other effects. It also causes hypovolemia, hyponatremia, and hyperosmolarity, and the effect of it. So then we talked about the bicarbonate therapy in lactic acidosis. A lot of studies talked about it, and they found that there is a lot of harm than advantages using it in lactic acidosis, because the mechanism here is not a loss of bicarbonate. It is basically because of unmeasured anions or acids which are formed. So if your liver and kidneys perfuse well, and if you're able to metabolize it, they are much safer to do that way. So studies have shown again here that when you are trying to improve the pH by giving bicarbonate, your intracellular pH drops in most of these studies. So what are the guidelines by surveillance sepsis? They say that there is no advantage of using a bicarbonate therapy when your pH is more than 7.5, and there is no real studies to prove whether it benefits in a lower pH. And again, in DKA, by giving you a bicarbonate, you can increase your PCO2 that can harm and cause cerebral edema. And the indication for a bicarbonate in DKA is when you have a severe hyperkalemia, or when you have a point where you think the pH is so high that you're unresponsive to vasopressors. Bicard is one of ICU studies, one of the landmark study where when they compared about the use of bicarbonate in a severely metabolic acidosis, they found in normal patients it did not cause any benefit. But in a subgroup of population who have a AKI as per the stage 2 or stage 3, they found there was a slightly benefit in the mortality and the need for the CRRT in these patients. Bicarbonate and cardiac arrest, many of us believe in giving anything. Again, studies have not proven any outcome benefits by giving bicarbonate. And so there is no recommendation for using bicarbonate in the cardiac arrest scenario. It has some role when you give it after a prolonged pre-hospital arrest, because as I said, severe acidosis and catecholamine unresponsive can be slightly improved when you are having a prolonged cardiac arrest. Alternatives to bicarbonate therapies in the form of TAM. What is the advantage of it? As I said, when you give bicarbonate, it can convert into carbon dioxide and cause problem. TAM doesn't make the change of generating carbon dioxide to that extent, and it is freely mobile. But the problem is it is excreted by the kidney, and by giving this, you can have a risk of hyperkalemia, you can have liver necrosis or hyperglycemia as a side effect of it. Carbicarb is nothing but an equimolar concentration of sodium bicarbonate and bicarb. Again, it produces less carbon dioxide, but it is not much used. Dichloroacidosis acetate has been tried in lactic acidosis, where it increases the conversion of lactic acid to pyruvate, thereby helping in bicarb, reducing the acidosis and lactate. The final question which most of us have in mind is dialysis and management in metabolic acidosis. We all know when you have an uncompensated metabolic acidosis, there is a role. And what kind of renal replacement therapy to use? Definitely, PD may not be a source if you have a hyperperfusion, because it can not have a good perfusion, so that the good diffusion is going to happen, or it can increase your abdominal compartment pressure, thereby reducing the good perfusion. Intermittent is a rapid procedure which we don't do in an unstable patient. When you do a CVVH and CVHT, people think of benefits of it. By doing a dialysis can easily improve, but the downside of it, you can have a problem is if you start a lactate buffered solution, normally the body has a capacity to work well. But in the case when you have liver failure, this lactate can accumulate and the serum lactate level can slightly rise. So if you have lactate intolerance, it is better not to use a lactate buffered solution. Instead, you can use a lactate-free solution. So there is a study which talks about the advantages using a lactate-free dialysate instead of lactate buffered. They found that the blood hydrogen ion concentration reduced rapidly when you use a lactate-free solution. And they also found the acidosis improvement rapidly in a lactate-free solution. The BP and the inotropic requirements also slightly improved when you use lactate-free solution. But the problem when you use a bicarb-based solution, there is a risk of precipitation because normally a dialysate fluid also has magnesium and calcium. Another problem you may have is your bicarbonate solution are unstable. It can diffuse and cause carbon dioxide, and if your ventilation is not properly managed, it can cause problem more. So by saying all these things, it has to be looked whether are you going to benefit, because your lactate metabolism is key when you decide whether you want to do a buffered or lactate-free solution. And if your liver is good and if you are able to do a good thing, that is the best way of removing lactate than your bicarbonate-based dialysate fluid. So take-home message from this would be only extremes of an acid-base disorder like pH of less than 6.8 or some more than 7.8 are lethal to the cells. Understanding of the base of the acid-base disorder is more important and rather than following the acid-base disorder. As I said, lactic acidosis, metabolic acidosis has worse prognosis when compared to metabolic acidosis because of hyperchloremia. Bicarbonate therapy is more complicated and except in few conditions. Not all need lactate-free dialysate fluid, as I explained. And when we manage somebody or when we try to understand the acid-base balance, both Anderson-Isselbach and Stewart principle has to be used to appropriately find the cause for the acid-base balance. Finding the underlying cause of metabolic acidosis is more important in correcting the problem. Utran alavum, piniyalavum, kalamum, katran kardi sayal. The habitudes of patient and disease, the crisis of the illness, that must be learned, reach, think all over well, or the doctors have to think about it and then they have to apply their knowledge for the same. Thank you.
Dr. Satya Prasad?
1 minute. Yeah, thank you, Dr. Ravikumar. It's a very nice presentation. Now we'll go to question and answer session. This is to Dr. Muthiah.
Yes, sir.
How good are the biomarkers in predicting the impending AKI? Are there any differences among individual biomarkers in predicting AKI? This is to Dr. Muthiah.
Yeah. First, I will say what I know, then I think you can supplement. So as far as biomarkers in AKI is concerned, it's a evolving thing and it's the future. We have certain biomarkers mostly not available for us. Except NGAL, I'm not aware of anything commercially available. And NGAL, cystatin C, fatty acid, FABP, and proteins are all available to be checked. So the biomarkers are at least for 24 to 48 hours before we can predict the AKI from what the evidence is present. And the studies are limited to post-cardiac bypass cases, where there is like post-cardiac surgeries, when there is a post-cardiopulmonary bypass, when there is already a SIRS going on. They have checked, when there is a low urine output, they have checked NGAL in the urine and they have estimated, and the estimations were quite good when they did with NGAL for post-cardiac surgeries. Whereas in CKD patients, they have used cystatin C. And these two, there are differences. And FABP, interleukin 18 and all have been discussed in other patients. There is various timeline, I think. NGAL is what I think is the most earliest one to raise. And IL-18 is like little after 12 to 18 hours. This is what I remember. but I'm not very sure. So I think biomarkers are the future, but it's too early for us to, it's not commercially available. So it is difficult for us to say how much it will help in predicting decay. So far, it is predominantly, the routine ones, the urine output, the creatinine, and all those things. Thank you.
That's quite correct. Yeah.
So I think others can, Dr. Satya Prasad, Dr. Kaliman can add, the Ravikumar sir, if you have any inputs.
This is nicely covered. Still, this is evolving, the studies, biomarkers, and those things.
I think we had a
So
talk
this
in,
is
in biomarkers by Dr. Prasad Devarajan. He discussed in detail.
again another question to Dr. Muthiah. Is the bolus volume of 20 ml is a fixed one?
No. There is nothing like a bolus, fixed bolus. Now we are questioning all the bolus. So there is nothing like, but I think if the patient is hypovolemic, definitely we have to give them fluid. Like early sepsis, there is a clear-cut fluid loss, like through diarrhea or something, we have to give fluid. But if there is a clear-cut hypovolemia, hypotensive thing, then maybe 20 ml per kg over 1 hour is okay. But nowadays the practice has changed. As we have seen the studies, we prefer to give 10 ml per kg because we don't know the myocardial dysfunction which these patients may have to start with. At least we tend to give 10 ml per kg if the patient is not very badly hypotensive. Like if the patient is not having a poor central pulse or impending cardiac arrest or something, I think 10 ml per kg will do over 1 hour. And again, most of the times now we have moved from 20 minutes to over 1 hour slowly and assessing the responsiveness, like the positive effect and the negative effects of the fluid bolus. Like one side we have positive responses like heart rate resolution, sensorium improvement, urine output that may not be available in the first hour. Generally the perfusion improving, pulse is getting better, BP improving. But later on, like we get to know, like after the bolus, we need to monitor the with the help of ultrasound. The fluid responsiveness test can be done, and echo, the functional echo is available at most of the places now to check the LV pre and post bolus. All these things will help. So I think 20 ml per kg is not a fixed one. We have moved from the 20 ml per kg. In fact, we give it in smaller liquids. We give and see, something like even mini bolus. I didn't discuss those things. The mini fluid challenge, like 5 ml per kg, like adult people practice to a 200 to 250 ml fluid challenge. When the patient is fluid responsive, but there is, you don't want to give more fluids. Like there is a harm also, like fluid. When you think like that, maybe a mini fluid challenge will help. So 4 to 5 ml per kg, or maybe moving to colloids. So at least in initial phases, we are giving 10 ml per kg over 30 minutes if the patient is shocking, hypotensive, or over 1 hour if the BP is fairly okay. So that's the current practice. And we tend to give the second bolus or third bolus depending on the response. But not more than 30 ml per kg nowadays. Unless the patient is having cholera or something like that.
Dr. Satya Prasad, I think in between you had left a question. The second question was, does the evacuation phase spreads over the weeks irrespective of underlying condition?
Weeks, okay. Does the evacuation phase spreads over to weeks? No, actually, this is just a study thing which the Rose concept told us. But actually, we start evacuating, after 48 hours only to these days. If the patient is hemodynamically stable, and if the patient's primary disease is resolving or resolved, that is the time you start evacuating. There is no exact cutoff even, but some patients may be requiring the organ support based on the etiology. For example, if it's a septic shock, maybe we don't disturb for the first 72 hours. But whereas if it is a patient of a CKD, nephrotic syndrome with some problem leading to acute hypovolemia, we tend to give and then we start removing. So it depends on the primary disease and the state of the disease. So some patients who come late phases of septic shock and especially who are not fluid responsive, we start removing early. When the lung is bad, again, we start removing early. At least we try to maintain the neutral balance in moderate to severe ARDS or patients who are having predisposition to fluid overload. we try to at least maintain neutral balance after 48 hours of fluids, not for the first 48 hours. And the evacuation phase generally doesn't go on for weeks. It depends. It depends. Maybe a week or two, till which we try to maintain the patient negative. And then we try to, and then the phase comes when we hydrate them. We give them more nutrition. In fact, now the nutrition is more important in ICU. We try to maintain them positive. And even the nephrologists want the patient to maintain them positive. So when that allows, when the situation allows, we try to maintain euvolemia, try to give them good nutrition. Those things are also important when we are weaning out of ventilation. At least to extubate, fluid balance helps. Post-extubation, if the patient tolerates extubation, then that is the time when we reconsider evacuation and we start supplementing them with nutrition and other things. That's what stopping fluid is also equally important as starting. Right time of stopping, introducing fluids, nutrition is extremely important as we are starting.
So this question to Dr. Ravikumar.
Yeah.
Infants with severe metabolic acidosis who is not responding to conservative fluid therapy, whether to go for peritoneal dialysis or CRRT. Which one is the better option?
Here comes in the thought process, what is the cause for it, whether you are having a hemodynamic stability, whether your perfusion is good, whether you are whether you are good in getting an access for CRRT. What is your primary metabolic acidosis? Was it because that is also determines whether you will be able to remove the solute if it is going to be most of metabolic acids, and all those determines your thing and your expertise, what you're comfortable. But there is no point in saying that one is completely superior over the thing. It is based upon your perfusion, it is based upon the resource availability with you and the response for whatever modality you start. That is the key to start with. But if you think you are hemodynamically unstable, if the perfusion is poor, I think PD may not work. In that case, starting a CRRT will be better, and definitely a continuous renal replacement, because you may have instability if you choose anything else.
Okay. Dr. Satya Prasad, there are a few other questions in the question list.
While selecting IV albumin nephrotic child with severe relapse and hypovolemia, presenting with abdominal pain, high hematocrit, and PINA is less than 1%, 5% albumin should be better than 20%, since 20% albumin has high osmolality and may not be very safe in such cases. What is your impression? 20% albumin is better to just treat edema. Kindly share your inputs to Dr. Muthiah.
Yes, sir. Actually, it's a good question. In nephrotic syndrome,
nephrologist will be taking up the questions. Like you can give your input, we'll add on to it.
Definitely, ma'am. So what, if there is a shock, if the patient is in shock, it's, as they've told, PINA is less than 1. We don't see PINA in shock because it's too acute. And we are on IV fluids. So PINA may be having, fallacies to it. We can't see the PINA. But if it is predominantly a pre-renal thing, high hematocrit, as they have told, like in dengue or even dengue, it's not pre-renal. It's like both. There is fluid leak and there is pre-renal also. If whatever may be the scenario, the first bolus will be a 5% albumin from ICU side. Like we give a 5 ml per kg, we can't give a 5 ml per kg 20% albumin to a non-intubated child at least. So we need to give only 5% albumin to see the response. Basically, whether the patient is responding to colloids, and in that specific case, who is having an albumin of 1.5, we did give 1 gram per kg 20% albumin over 6 hours. Over 6 hours, it was not like a bolus, just to boost the thing and to maintain the oncotic pressure to prevent further leak. It was just like that. But in acute phases of shock, we do use 5% albumin as a resuscitation fluid. It is not 20% albumin, and it is given over 1 hour. And it's carefully monitored. Albumin needs to be carefully monitored, because if the patient is leaky, they can develop hypoxia, they can develop cardiac failure. They need to be monitored. And we generally give 5 ml per kg of 5% albumin to a maximum of 100 ml, even for a big child. We just give over half an hour to 1 hour and see the response, and then we decide. So I think for resuscitation, it's still 5% albumin. In that specific case, we did use 20% albumin, 1 gram per kg over 6 hours. So, it was like just to improve the oncotic pressure to improve the retainability of the things. So still it is 5% albumin for resuscitation point. I think others can add onto this.
I think like it all depends on serum albumin as well. If the serum albumin is very less, I think there is no harm in giving 20% albumin. And for the purpose of, what is the purpose of giving albumin also matters. In a child with relapse and you want to bring down the edema per se, then your 20% albumin works better than the 5% albumin. But you have to look at as Dr. Muthiah said, you have to look at the lung status as well.
Okay.
The volume also, if you are using 20% albumin, the quantity is less compared to 5%. And anyway, 20% albumin also you are giving slowly over 4 to 6 hours. Always we have to give along with diuretic, Lasix. So if you are going to take care, obviously we can prevent pulmonary edema.
Yes, an intubated child is fairly safe.
Even in Albio study, when they had shock with hypoalbuminemia, by giving 20% albumin, they did not find shock improving or did not make any difference. So when you have a hypovolemia, first correct the hypovolemia and then use for your consolidation phase 20% albumin. That will be the way to go.
The purpose of giving albumin matters. For what purpose we give albumin?
Yes.
And the next question, Dr. Satya Prasad, the next
question to Dr. Ravikumar. This is about a 1-year-old girl with severe dehydration, has hypernatremia. Sodium is 185 and pH is 7.2 with bicarb of 10 with base deficit of -10. How do you approach?
Definitely, I would look in whether hydration is correct now, because you said severe dehydration is there. I'm sorry, did I miss?
Yes.
Severe dehydration with hypernatremia. Sodium is 185.
Okay.
With dehydration, with metabolic acidosis, pH is 7.15 with bicarb of 10 with base deficit of -15.
Okay, here one is dehydration. I would definitely start a fluid with less of sodium to start with, because of hypernatremia dehydration. Something like Kebilite, or if there is a shock, I would try to replace. Otherwise, I'll use a half normal saline. Improve slowly, try to reduce your hypernatremia. But saying all these things, the metabolic acidosis, I need to calculate what is the reason for this metabolic acidosis. Because looking into this picture, we may need to know what is the underlying cause for this metabolic. Was it just a sufficient only dehydration, or is there any underlying background wide anion gap metabolic acidosis, or you have underlying something RTA-like syndrome which is being presented? So we need to look at the anion gap, look into whether it is fitting into RTA or just hypovolemic causing a dehydration. Correcting the underlying cause will be the first thing to improve your acidosis. With that, if it is not improving, and if you think a mixed disorder coming in place, I think then there is a role for further evaluating what is the cause for the acidosis.
Yeah, so first, any child with hypernatremic dehydration, anyway, we have to give NS, 0.9%, is it? So
Yeah.
First give bolus and assess again, repeat electrolytes. So we have to see whether sodium is coming down or not. Then accordingly, we can titrate the fluid, obviously. So if this is because of dehydration, obviously with fluid correction, fluid resuscitation, acidosis also will improve. If you have any mixed disorder, obviously, yes, we have to evaluate further and we have to see. Exactly. Same question, is there any role of dialysis if sodium is persistently high?
Yes.
Conservative measurement, if sodium is not coming down more than 175, what to do? Is there any role of dialysis?
Yes, there is a role for dialysis, and we have seen one of the indication is actually hypernatremia, which is uncorrected. You have a role for dialysis, definitely, because you don't want a rapid fall in the sodium at the same time, or you don't want it to have a very high, because hyperosmolar again is going to damage your kidney and you may not be able to solve the issues. And I want to know what the nephrologists feel.
Yeah, obviously. So if sodium is high, If you're not able to correct it, so with the conservative management, obviously we have to give support, either peritoneal dialysis or CRRT if you have facility. Only we should be careful if you are doing peritoneal dialysis, you will see rapid shift of sodium. So sometimes we do add 3% NaCl to PD fluid also to narrow the breach.
Yeah.
Dr. Muthiah, is severe acute malnutrition also it is 15 ml per kg advocated as bolus?
No, in severe acute malnutrition, they have severe cardiac dysfunction, basically, and they have anemia also in the background. Usually, they have some children, we try not to give bolus. And even if we give a bolus, maybe 5 ml per kg slowly, we try to give blood sometimes as a bolus over 3 to 4 hours if they have severe anemia. We, in severe acute malnutrition, any fast even fluid replacement can cause cardiac dysfunction very quickly. So we don't give 15 ml per kg. We give 5 ml or, in small liquids, 5 ml per kg over 1 to 2 hours and then see the response. They have other issues like hypothermia, hypoglycemia, sepsis, anemia. I think once we start correcting those issues, acutely electrolyte imbalances, I think if we start correcting them, the shock also kind of gets better. Fluids, we have to be extremely cautious, especially in resource limited setting. Giving 10 ml per kg fast or more than that is harmful. We need to have invasive ventilation background in our backup because these children don't have good muscle function also. They quickly deteriorate. They quickly go for CCF and pulmonary edema. So we give 5 ml per kg if there is signs of shock. Over and slowly. We don't give 15 ml per kg. And their albumin is also low. Their albumin is also low most of the times.
Yeah. So next question to Dr. Muthiah only. So in cardiogenic shock, is there any role of dopamine nowadays?
So dopamine, we have used long back in some situations in my PT days during my government colleges, but actually nowadays we don't use dopamine anywhere. In pediatric situations, even in post-cardiac surgery, some units use dopamine. Post-Fontaine surgery, some places where still they believe dopamine low dose for improving splanchnic perfusion and renal perfusion, but dopamine is slowly moving out of the disc. All the studies, the adult and pediatric, are all showing, even from MBA, they did a dopamine RCT in dopamine in children. So that all showed increased heart rate. And with dopamine, more problems with dopamine, then especially in cardiogenic shock, we want the heart rate to be in control, right? We don't want the diastolic time to come down. We want good diastolic filling at the same time. We want good perfusion. So dopamine as such, at higher doses, it causes alpha stimulation, vasoconstriction. At low doses, it doesn't benefit. It doesn't cause any aneuploidy. So in cardiogenic shock, basically, dopamine is useless. So you want to use, you can use adrenaline or milrinone or even low dose norepinephrine, but not other vasodilators like inodilators like milrinone, levosimentan, or dobutamine. Even dobutamine can be used in peripheral settings, or places where it's not available or experience is poor with milrinone and levosimentan. We can use dobutamine in cardiogenic dysfunction when the BP is good. But dopamine, I think, is out of context. We don't use dopamine in cardiogenic shock.
This is to Dr. Ravikumar. Children with DKA.
Newborns in sepsis, they are still using dopamine. They feel the poor response with their alpha receptors are poorly responding. So they still use dopa-dobutamine combination. It works well in newborn sepsis, I feel. But in pediatric, it's after 2-3 months, I think we are preferably using adrenaline and norepinephrine for sepsis.
It is actually immunosuppressant. It is more arrhythmogenic. And as you said, it is more a chronotropy than your inotropy effect. And it acts through only your catecholamine. So if your catecholamine reserve is not good, dopamine is not going to work. So it's not going to work in a severe shock person.
The pH is important.
This question to Dr.
Yeah. Sorry, Muthiah.
Question to Dr. Ravikumar.
It's okay, sir. It's okay.
Children with DKA with pH of 7.1, around 7.1, does they require bicarb supplements?
As I said already in my talk, it's like we don't need to give bicarbonate. in DKA per se, because when you are there, if you look at your gases, your PCO2 is very low, and it is one of the way of mechanism to prevent your cerebral edema. Rapid rise of PCO2 is associated with cerebral edema. There is no indication. Studies have not shown bicarbonate role except when you have a severe hyperkalemia in a DKA, or rarely when you have a pH falling less than 6.9, where you have a shock and you're on multiple inotropy and you're not able to have your hemodynamic stability. Otherwise, no. But see, most of us have not used bicarbonate mostly in DKAs recently.
Yeah.
I think there are a few other questions in the question, doctor.
1 minute. Let me see these only. In cardiogenic shock, cut off fluid bolus. This is to Dr. Muthiah.
Again, see, we don't give fluid boluses in cardiogenic shock. Only the initial phase, we may give 5 ml per kg or 10 ml per kg. They do require some preload because, you know, the inotropes, they all need some cushion. So we give some, it's all etiology based, okay? So the preload is, when it's a fluid bolus, the indication is to optimize the preload. It is, when the preload is less, when there are obvious hypovolemia signs, then the fluid will work. Otherwise, hypoperfusion will not get better with fluid alone in cardiogenic shock. Because the problem is different. It is with the pump. It is not with the periphery. So when the pump is failing or when there is a problem with the diastolic filling, we need to sometimes we need to give early invasive ventilation, mechanical support, inotropy. Those will help much better in cardiogenic shock than fluids alone. I don't think fluid boluses, there is no cutoff as such, but we try to maintain the neutral valence from day one only in cardiogenic shock. In cardiogenic shock, we don't allow them to be possible for 48 hours or 72 hours. We try to maintain neutral valence. Although they would have required initially some bolus, we try to reduce our maintenance and we try to give minimal, sometimes 40-50% maintenance fluids for them and target negative balance. Sometimes, take help of early invasive ventilation, early RRT if the BP allows us. And sometimes, if nothing works, then mechanical support can be. We have to go for IPNA or other pad and other supports. But I think it all is contextual. It is based on the etiology. The primary etiology, if it is hard, fluids won't work after optimizing preload. And in post-op cardiac surgeries like stiff RV and those conditions, we do give more fluids. That is totally a different arena. There, it's like you give fluids initially, it's SIRS, there is some leak, and everything going on. In a pure myocarditis child, we don't give fluid boluses. We try to avoid maybe a 5 ml per kg initially and then go for ventilation and inotropy. Early vasoactive is the key. Even if the pH is low, we try to start adrenaline and sometimes vasopressin if it doesn't work, low dose. Everything helps, but not fluids.
This is to Dr. Ravikumar. Is there any role of heme absorption in metabolic acidosis secondary to poisoning, intoxication?
I fairly don't know, and I have not used heme absorption even in a septic shock, so I don't know whether it really helps.
I would like just to take up this. We had used once in one case heme absorption, but we don't know how it helped actually. We used charcoal heme absorption, but actually the child got better in an unknown poisoning child. We don't know what it was. It was like phenol or something, they said. It was not clear. So we were desperate. So we used. So it is not very clear heme absorption, but it's coming up in a big way. In some cases, there is a role like there is something called as this in North India, the pesticides that sulfos they call sulfos. There they have tried some heme absorption, but there also it is of not a great, the plasma exchange, those things are more important than early CRRT plasma exchange. It's not very useful. I guess sulfos, they call it sulfos, for aluminum phosphate or something like that.
If it is a clear-cut poisoning, then heme absorption really plays a role. Otherwise, like just trying alone does not help.
Initiation, the timing is also so important. You have to start immediately as early as possible. Otherwise, once drug is bound to protein, it's very difficult to replace it. Yeah.
So I think we are done with
most
the
of the
questions.
questions. Yeah. It's a very nice session. It's a very good interaction. So, yeah. Our co-speakers, like in detail, explained everything about metabolic acidosis in sick children and fluid therapy in PICU. Thank you.
Thank you so much, Dr. Ravi. Thank you, Dr. Satya Prasad. Thank you, Dr. Muthiah. It was a wonderful discussion. And the next webinar will be not on the usual scheduled date on Wednesday. It will be on 24th, which falls on Tuesday. So it is the most expected talk by Dr. Goldstein and by Dr. Baha. It will be falling on Tuesday. Thank you so much, Dr. Ravi. Thank you, Dr. Satya Prasad. It was an excellent moderation. Thanks to both the speakers. It was an excellent session in detail, justifying the topic given. Thank you so much. Good night.
Thank you.
Thank you.
Thank you.
Thank you. Bye-bye.